Welcome back to Vegas OrthoDoc. I'm Dr. Jeremy Manueli and I'm glad you're here. Today we've got a pretty incredible transformation to share with you. We're going to be taking you on a journey that started out when this patient was just 7 years old, and trust me, you're going to want to see how this turns out. We're not just moving teeth here, we're literally reshaping bones and guiding growth. And then we're using tech, specifically what we call a 3D superimposed CBCT images, to see the changes happening in real time. Before we dive in, if you love seeing these deep dive cases, be sure to do us a favor and like this video and subscribe to our channel. It really helps us to keep bringing you these orthodontic transformations, and hey, your future smile just might thank you for it. Now let's go ahead and dive in. Okay, so this presentation is appropriately titled MSE plus Facemask, so you'll probably see why soon. But we're going to go through some things together first before we get there. And I wanted to give you a more comprehensive view of treatment, because you guys see a lot of the phase one, but then oftentimes you either don't see the results of the phase one and or what happens in phase two and what happens with the growth. So we talk a lot about the growth, but I don't think you guys have really seen the growth a lot. And so we're going to go through things together. We're not going to pick this case apart like we do normal cases, like to quite the level of detail. We'll go over everything kind of at the same time once I get my clicker to work. Here we go. All right, so patient presents 7 years, 3 months old. We'll just go through, we're not going to go through every picture individually, but why don't you guys just glance at these as a whole and tell me some of the things that are standing out to you. And so you can do one of a few things. You can be the one that just throws out a problem and make everybody else answer the questions about why it's relevant. Or you can throw out a problem and then start brainstorming, like why are some of these things that you're seeing significant, and how are these things going to play into this child's treatment and also their life if you don't treat, that kind of thing. So looking at the images, what are some things that stand out to you? So go ahead and pick an image, pick a problem, and we'll start there. Okay, a lot of people said crossbite, and one person said canine crossbite. And so we do see a canine crossbite there on the right, primary canines. What is significant about that? Okay, and why is that significant? Why is it significant if the lower canine is outside or the upper canine is kind of locked in compared to the lower? Why is that significant? Okay, so a shift could be very significant. And why would a shift be significant? Yeah, it can change the growth trajectory, right? So if you have a shift and it's untreated, the jaw can either do one of two things. One, continue to shift over to that side, which is actually ideal, or two, it starts to grow that way, which is usually what happens, and then you have an asymmetry. So if we're suspecting an asymmetry, and we see, right here, we see this overlapping, we see it overlapping here, what are some other little landmarks that we can look at that might tell us, hey, yes, this might be, okay, yeah, maxillary and mandibular midlines, right? So what do those look like from best we can tell from these photos? Which one shifted to the right? Yeah, the mandibular, right? So the maxillary midline seems to be pretty on with the face. The mandibular seems to be to the right. So if you're noticing that, what is one piece of information for sure that you're going to want to know to help determine, what the prognosis of treating this would be? What are you going to need to know that you cannot see in these photos? If it's a shift, right? You need to know, like, are they still shifting, or is it actually already shifted that way? So this is a case that you're going to want to manipulate the jaw and see when that jaw is relaxed, when they're opening, does that lower midline go back onto the middle? Does it go halfway back onto the middle? Does it go all the way to the left? I doubt it. Or is it still pretty much exactly the same off to the right as it is now, indicating that that growth is already symmetric? What other landmarks can you look at besides the midline to kind of help and see, like, what's going on with this? Like, how much is it? Yep, you can look at the molar classification, and what would you expect if it shifted? You would expect what kind of a molar on the left side compared to the right side? The left side would be more class 3 or class 2? More class 3, right? That left side would be more forward. If the jaw was shifting, right side would be more class 2 or class 1, which is what we can see here. We can see that the lower molar here is more anterior. The molar here is kind of more straight up. And so again, this is all indicating that either, a shift is either happening or has happened. And what's one other thing you can look at if you just had the top 3 photos? You can look at the chin, right? So you can kind of see, like, looking from straight on, is that chin off to one side? And what else will you often pick up on if the chin is off? And you can see it best in this photo. There's actually two things. There's one thing on the upper left photo there, the rest photo, and there's one thing on the center photo there. So anybody know what I'm looking at? What's that? Okay. Not exactly what I was thinking. Dimples typically are going to be associated with either the same or differential smile pull. Can be associated with some weird swallowing patterns, but not necessarily the asymmetry in particular. But let's focus on that frontal rest photo for a minute. What you notice the chin's off. What else might be off if there's an asymmetry? The lips, right? So oftentimes the lips are going to follow to some extent the lower jaw. And so even if you don't have you put your jaw off to the side enough, you'll see an asymmetry in the lips there, which we do see with which side being more inferior. Yeah, the left side more inferior, which kind of makes sense. As that jaw shifts over, this is going to come down, the other side will raise a little bit. Now, what about in the center photo? Going along those same lines, if the chin is over to the side, maybe the lips are a little bit over to the side. The lips can be over to the side for a couple of reasons. One is the chin asymmetry. But what else might have happened, and what else can tell you, like, maybe this shift has been going on for longer versus not as long? What do you see in the center smiling photo there that's kind of a little bit off, besides the lips or chin? Yeah, she's got a cant, right? And which way is the cant? Kind of all adding up. Which side is inferior? Yeah, her left side is inferior compared to the right side. So now there's multiple reasons that a cant can be caused, right? But typically, if there's a cant, that it could just be the way that she grew. But we're tying that together with the fact that we know she's in a crossbite. It's more likely to develop a cant on that left side to come inferior, all right? So all of this is telling us, well, maybe, maybe this has been going on a while, and maybe this is more of a sign of actual growth. But again, we'll want to check the CRCO slide to confirm that. Now, give me one argument why the midline, may be off due to something other than growth. Like if you had to make the argument, you're on opposing counsel, even though you agree they're guilty, but you got to come up with something. All right, what's that? And okay, so trauma is definitely, yeah, I like it. You could throw out the case of trauma, like no, she had trauma. It could be, right? So if it was trauma, we could look at the pano, we could look at the ceph, we could see what the condyle heads look like, we could see the body of the mandible, the heights of both of those, so we could check that out. What else? Habits. Okay, why habits? And how would habits affect that? Meaning that so like the blanket kind of caused the teeth to move a little bit and go into that. Yeah, it's possible. It's possible. All right, what else? Kind of something that's staring at you more toward the front that you is not super relevant in this case. But again, if you had to make an argument for something that could have caused maybe a midline shift or yeah, you might have had early tooth loss. Now, it doesn't look like this is actually early tooth loss, right? It's probably going to lose the lower left primary lateral incisor soon. And it doesn't look like there's an excessive amount of space loss in that area, but there is one tooth missing on one side and not the other. Whenever that's the case, especially when it's not the tooth that you would be expecting to miss, then you want to go into account and say, hey, have we lost space already? Have the canine back mesialized? Again, I don't think so. If you look at this photo down here, it almost was cropped to make it look like there was space loss on the right side, but I think that's just the orientation of the photo, not where it actually is. All right, so I think we beat the crossbite to death. What else do we see on this case? Any other concerns? What's that? Okay, S, A, E, F, J, K, O, P, let's see. So lower, I know, I was do that. What is it again? Perfect, thank you. Lower right D looks like it could be ankylosed. Okay, I agree, awesome. So looking here, and you can see that it is below the occlusal plane, right? So what are you going to want to do to that tooth? To see, what's that? It is a good catch. Yes, a very good catch. All right. So now, what would be some signs that could be causing a problem?
What would be signs?
Yeah, what would be signs? If this were, what problems are you looking out for when you see an ankylosed tooth like that? What are you trying to pay attention to? Okay, so super eruption of the opposing teeth, which maybe a little bit. Maybe that canine is a little further down. Hard to tell. Gingival margins are pretty close. It could be. I mean, it could be interfering with the maxillary canine. Hard to tell from the photos here. Super eruption could happen. Now, what if like multiple teeth were ankylosed on that side? Then what could develop on that side? Going along the same lines as the super eruption, it could possibly develop a slight cant, right, in the maxilla itself, which we've already pointed out the cant is in the opposite direction. But like again, so ankylosed teeth, why does it matter? Why does it, you caught it, which is a great catch, but why does it matter? What do you have to pay attention to? What are you thinking in your mind? How do you change your treatment plan? Okay, yep, you could lose space by those teeth super erupting. You're going to want to check for a missing permanent tooth for sure, right? I mean, higher incidence of missing permanent teeth under these ankylosed teeth, so you want to check for that. And what are you going to do about this, possibly? Well, what are you going to do at a minimum with an ankylosed tooth? You're going to follow up for sure, right? You're not just going to see you in 4 years, when all your permanent teeth, not that we do that anyway, but it's something you're going to want to pay attention to because this could easily turn into a big problem. Now this is ankylosed what? Let's just say maybe like 1.5 millimeters, 2 millimeters. So not like super duper significant possibly. The left side, if you look at it, actually may have a slight similar tendency. If those first premolars are coming in, right underneath those teeth, maybe not a big deal. Maybe you don't have to do anything. Maybe you just let the permanent tooth, come in on its own. But if you're not paying attention and monitoring it, to your point, then you're all of a sudden you're looking and it's like all the other teeth are in and these lower first premolars are, the roots are completely formed and then you're like, oh crap, we better extract it, and then you extract it and then all of a sudden it's like, the tooth isn't coming in normally and you're sending them to the surgeon to dig out a tooth that really could have been prevented by just getting the primary ankylosed tooth out of the way. Yeah, not a thing that happens super often. Normally we catch those things, but something that if you're not looking for, you might miss. All right, any other things that are standing out to anyone? We haven't really talked much about the jaws other than the shift. So let's kind of talk a little bit more big picture about the jaws. We talked about the shift, we talked about the cant. Okay, so we really haven't talked about AP at all, right? So what are we seeing from an AP standpoint? What are your concerns? What's good? What's not good? Like, what are you noticing in the profile? Okay, minimal overjet. So there's minimal overjet, and that's associated with which type of skeletal pattern? Class 3 skeletal pattern. And Class 3 skeletal pattern means either what or what as it relates to the jaws. Where are the jaws? Okay, mid-face or maxillary deficient or mandibular protrusion, right? Okay, so now, again, we haven't looked at our Ceph yet, but what are we starting to brainstorm and think about when we look at this case? Like, what might be going on? What are some of the things that you notice that would lead you to believe it's one of those things over the other, and why? Okay, so when you say a flat profile, say that a different way so everybody knows what you're talking about. So when we look from the forehead to A point to B point here, it's a pretty straight facial profile, right? So it's not as so it's not as convex as we would oftentimes see in these younger patients with the lower jaw and the chin setting back a little bit from the upper jaw and then having that catch-up mandibular growth around 12 or 13. So I mean, when you look at this profile and what else? So you said so we're looking it's kind of like straight or flat here. What do you see here? Like, what does it look like here? Does this look like completely normal here in the midface, or like how would you describe it? Yeah, a little bit midface deficient, right? Now what when you look at this is not adding up with midface deficiency? Like you're looking, it's like, well, why? Oh, midface deficient usually has this, but this case doesn't. Like, what's going on with? Well, there is an upturned nose, but even still with the upturned nose, the nasolabial angle is, probably close to 90 degrees, right? Which is like pretty close to normal, but you have the upturned nose as well. So it's almost like you have this fullness in the upper lip that we don't typically see with midface deficient patients, right? And so, that can be for a number of reasons. And again, we'll look at the pano, or the Ceph. Maybe it's just that she's got great lips, right? And you just got a lot of lip fullness. And again, we'll see that if that's the case on the Ceph. But does anyone want to make the argument of mandibular protrusion? No? Nobody. No takers on mandibular protrusion. So you guys are envisioning.
The shift could be bringing it forward a little bit of that canine if it's sliding on that.
No, go with that. That's exactly what I was going to tell you to look at. So think about the FMA. And okay, but you're on the right track though, right? Because like if we're thinking about what's happening with the mandible, right? Mandibular protrusion, right? Mandibular protrusion is going to present differently depending on the FMA, right? So if the FMA is more flat, then you're going to see the mandibular protrusion happen a lot more on the profile view, right? Because that chin's going to go forward. But if the FMA is steeper, if the mandibular plane is steeper, then they may have protrusion, but it will be camouflaged in the profile, right? You might see what in the facial photos if it's more vertical? Yeah, more dolichocephalic appearance, a longer face. So now we haven't talked about the facial height yet, but what do you think about the facial height? Yeah, for her age, especially, I mean, like this is a fairly long lower third, right? In all of the images we're seeing that. I mean, the middle third looks a little bit shorter, the lower third looks a little bit longer, and so like the forehead looks normal to me. The middle height looks maybe if anything a little bit smaller, more compressed, and then the lower facial third looks longer. Okay, so looking at the facial height, it looks a little bit increased. Now you mentioned that the mandibular plane angle doesn't look that steep. Why are you saying that? What are you seeing that is saying? Well, does everybody agree with that? First of all, hard to say.
Yeah, it's hard to say because you can't see her jaw. You would be able to clinically do.
Yeah, if you actually saw her moving, it would be a lot easier to see. Yeah. Okay. Well, I mean, like looking at these photos, if I'm guessing, I'm looking, okay, like it looks like it's probably somewhere here, right? Bottom, base of the ear down to the base of the chin here, right? So, I mean, that looks to be, at least on these images, pretty steep, right? So maybe we are making a case for some type of mandibular protrusion. But the cool thing about this case is we get to follow it and see what exactly happens. So let's keep looking, and then we'll see if we were right or wrong or right in both ways. All right. So pano, what are we seeing here? Any major concerns? What's standing out?
Well, she has a permanent tooth under that ankylosed one.
All right. And is there any signs that there's anything wrong with that permanent tooth at this point? No, not really, right? So any need to do anything with that primary tooth yet? No, we're not seeing the problems, right? The associated eruption of that side is not an issue. Honestly, if it was, it could potentially help us if that caused a cant or help corrected the cant that she has. So no reason to pull it out for that. Permanent tooth is the lower fours are ahead of the other teeth, which is where they typically are. You can see that the loss of that lower left lateral incisor looks to be normal. Wasn't like early loss causing space loss like we talked about. There's no missing permanent teeth that we can see. Maybe we can't see the developing third molars quite yet. We'll see if those are coming or not. But anything else standing out that you're overly concerned about here? Well, we haven't talked at all about crowding yet. Typically, we talk about that when we go ahead.
I'll just say that the condyles, you can see that there is more of a shift, or you can assume there's more of a shift because the left is a little bit more forward.
So yeah, it's kind of like chicken or the egg here, right? So if you look at the actual, well, two things actually. The thing you mentioned, the actual fossa itself, right? So when you look at this, and this isn't the best view of pano because there is distortion, but if you pulled up the TMJ film, which actually we might have, you'll probably notice the left side is more anteriorly displaced within the glenoid fossa than the right side here, which is a great pickup. The other thing, and again, we didn't super measure it here, but there may be, if you're kind of looking at the length of the condyles or of the mandible, the body of the mandible on both sides here, the height, if anything, it looks like, well, maybe this left side is a little bit longer than the right, which kind of adds up, but not a huge difference in the actual condyle length here versus, maybe a little bit. It's really hard to say. You'd have to measure it out to see. But, could have been trauma related. If this is shorter, the condyle head is shorter, then you're leaning more toward condyle related. If it's more in the body, then you're leaning more toward maybe shift associated or some other thing that would lengthen the whole entire body of the mandible versus trauma, which typically is going to affect that condylar portion. Now, again, we didn't talk about crowding. So, I mean, obviously the crowding was not significant enough that you guys thought it was an issue. Like, you didn't even bring it up on the photos. So now we see the pano. Are we concerned about crowding?
Well, I did notice that her mandibular incisors, the permanent ones, are already kind of tilted like this, away from each other a little bit.
Okay.
So I think as more permanents come in, yeah, we're going to run into crowding, personally.
Okay. So we have some crowding. So if you had to, from everything you've seen, would you call this mild, moderate, or severe crowding? Yeah, mild crowding. Now, let me ask you another question. If we did nothing, do you think these teeth will come in or not? What's that? 50-50? Okay, so that's not 50-50. So we're leaning more toward they will come in, right? And really there's exactly there's no real signs that anything major from a tooth standpoint is going to derail, canine impactions, or we're not going to have enough teeth room for the teeth overall within these jaws. Okay. So again, it's like, all right, well, what are we doing at this phase? Obviously we have some skeletal and facial concerns, but I mean, if it's a shift, I mean, you could extract the primary, you could do some really, really simple things to get them not shifting. All right. So now we have to really think about like, well, what is best for this patient and how are we going to manage this? Let's take a look at the Ceph here. Now that we can actually see the bones, does anybody want to make an argument about if it's mandibular protrusion or if mandibular protrusion is part of this or not? That's a very steep mandible, right? You see that mandibular plane angle here. So with this steep mandibular plane angle, and what about the occlusal plane? Is that steep as well, or is that more, flat, or what would you call the occlusal plane? Also pretty steepish, right? So what is going to be our challenge in comprehensive orthodontics with this case? What's going to be hard to manage during this case when we get to comprehensive especially, and we need everything to fit together? What is the likelihood or the tendency that's going to happen to this bite over time as she continues to grow in this? Okay, more class 3, all right? So what they call high angle class 3, all right? So again, when we're talking about class 3, we're talking mostly about the AP dimension, but what other dimension is going to be hard to control in this case? Well, you got a 50-50 chance. Now we are to a 50-50 chance. We got either posterior open bite tendency or anterior open bite tendency. One of those is correct. Posterior. We have a vote for posterior. We have a vote for anterior. We have a thought of anterior. Oh, we have 2 for anterior now. Anybody else? Well, we got 2 of the same vote for posterior. Well, let's hear the argument at least. All right. So, what is the argument for posterior open bite?
I think as that mandible grows from the condyle, it's going to open up the bite in the back. I don't see any reason for anterior open bite.
Okay.
You're hitting on your incisors first.
Not always.
Well, sometimes.
Okay. She is. I'll give you that. She is. So keep going. I didn't. Okay, meaning that like, so yeah, if you're hitting, then it could create a posterior open bite. Okay. Anybody else want to make or any other arguments for posterior? You almost had me convinced.
I see anteriors. I don't know why.
Okay. So let's think about this. You are correct that in a class 3 grower, if you end up with interferences in the anterior, meaning that the bite is not open yet, yeah, you can pick up some interferences, and for some extent, you can have an open bite in the posterior teeth. So that's correct. But what's going to happen if you pick up interferences on the anterior teeth and you can't get your teeth to fit together? What are you going to do functionally? So if you're growing into class 3 and your front teeth start to hit each other and it causes a posterior open bite because only your front teeth are hitting, what are you going to do? You're going to functionally shift which way? Well, definitely forward, right? So yeah, if you can't get your teeth to connect because your front teeth are interfering, you're going to shift forward and then your back teeth are going to hit again. And that's going to maintain the position of the back teeth. But as you continue to grow, the posterior teeth, especially in high angle cases, has a huge advantage over the anterior teeth as far as changing the bite. And that advantage is this lever arm here. So if these posterior teeth erupt a 0.5 millimeter on a high angle case, that could result to 2 to 3 millimeters open bite in the front because of the angle that they're connecting in. And so you are going to be much more likely to have an anterior open bite in high angle crowded cases than you are in like deeper faces, right? So in these, lower mandibular plane angle, steeper occlusal or flatter occlusal planes, it's like really, really hard to open up those bites. They end up really deep. It's like all these mechanics are happening and they're just, their muscles or everything's keeping you, closed. With the longer the face is, even the muscle pull, like if you look at the research on this, like patients with longer faces, the forces that they generate with their masseters, with their pterygoids, is weaker. And so like the bite is not helping you close as much. So when you see these high angle cases, this is like very, very challenging in phase 2 because these open bites develop and they're very, very difficult to correct. Okay, so we're going to be paying attention to that as she continues to grow. Now it's kind of funny because, well, I'll show you what happens because in a way you guys were both right, but but the biggest problem is how you fix it later, and that's going to be the anterior open bite problem. Any other questions about the Ceph or anything else that we see in the Ceph? Why is our nasolabial angle good? Is it because the upper jaw is forward? She's got nice lips, right? Yeah, she's got, you know, a really thick upper lip, and so again, the nasolabial angle is more normal. Okay, here's our TMJs, and they had mentioned before the anterior displacement of the left side. This is the best view to look at that. You can see a little bit of anterior displacement here, but it's certainly not all the way up on the eminence. So we know that the shift, if it's there, is not completely causing what we're seeing in the mouth. But again, you can see a little bit more forward position of the left condyle compared to the right condyle. No obvious signs on the condyles themselves of any like active resorption or any obvious signs of trauma. The right and left condyles look pretty symmetrical, pretty much about the same size, and one of them is not like super more different than the other one. You can see that the way that this was taken, this was cross-sectioned more anteriorly, which is a mistake. This should be right in the middle here, and that's why this one looks smaller. Is you're getting a different cross-section on the left side than the right side. But overall, these look pretty normal. Okay, so airway. All right, when we look at this airway, just tell me what you think about this airway. You know, first glance, like, are you thinking like, oh my gosh, I'm super worried? Or what are your first thoughts when you see this airway? You know, 40 millimeters minimal constriction. Are we worried? Are we not worried? Why? I know we've talked about this. All right, who's worried? Who's not worried? Who doesn't remember anything that we've taught? No, okay, so you're not worried. All right, so why are you not worried?
Because of the way that it is.
Okay,
Yeah.
all right, you just kind of feel it. Yeah, open bite, yeah, airway. Well, I mean,
the nasal area looks fine.
okay,
Like where the adenoids would be.
so up here looks fine.
Yeah.
All right, so okay, so down here looks not fine.
That can move like that.
Okay, so and when does that move, or how does that move?
Anytime they move.
Okay.
Yeah.
Okay.
Swallow.
D-
If she's sleeping.
falls back, then she's probably obstructed.
I agree. It will move because of that, but that's not why this one moved. At least not why it moved as significantly as it did.
It's not touching the roof.
Okay, but that also can affect that airway, but that also is not the main reason why this looks constricted back here. What's, yeah, sort of. Curve of the spine, head position, right? I mean, go like this, like try to breathe in with your head all the way back. Go forward, breathe in, right? So when your head is back, you can see this curvature of the spine. This head was in a very retruded position, which is always going to make this number look smaller. She could move her head forward, and that could turn into 200, okay? That's why, you know, this is an airway screening tool, not an airway diagnostic tool. And so we're going to ask the questions about sleep, of course, right? Because according to this should be at 7 years old, at least 80. But again, this is super subjective. So I'm in the camp of like, because of the head position, probably not highly likely that there's sleep issues going on, but you definitely want to ask the questions. Let's take a look at the jaw width. So I've talked to you guys about how we measure jaw width with cone beams. Hopefully this is how you're able to measure them. This is at the level of the first molars, all right? So how much of a discrepancy in millimeters do we have here? 4.5. We have 4.5. All right. Anybody else want to throw a number out? 5.5. All right. We got a little bigger number. All right. Anybody else want to throw a number out? 2, 6.5, 4. All right. We'll just throw all the numbers out. Eventually we'll get there. How wide should the upper jaw be compared to the lower jaw, ideally?
How wide should the upper one?
Yes, the jaw. Looking at the bones. Again, these landmarks are ideally placed in the middle of the bone. What's that? 3 to 5 millimeters wider. So if the upper jaw were to be 3 to 5 millimeters wider than the lower jaw, then how wide does that upper jaw need to be?
50.
Okay, so we'll say 50. You said 50, which is about 6 millimeters wider than the current lower jaw. So make your case for that extra millimeter. And if you get it, this will be a golden ticket answer.
Because it's going to shrink back.
What? No, but that's a good thought.
What's the exact question?
So the exact question is, he said that the upper jaw should be 50 eventually. I'm going to agree with him. I think that that is the target upper jaw dimension at this level of the first molars. But that's 6 millimeters wider than it is now. So how do you account for that extra millimeter?
The lower jaw is not going to grow as fast, and the mandible is going to have some more natural growth.
All right, good job. So this patient is 7 years old, right? So there is going to be approximately 1 millimeter of mandibular growth between the time she's done growing at 26, all right? So keeping on this thought process, the upper jaw is currently 40 millimeters. Does that mean we need to expand 10 millimeters? Skeletally? No. Okay, why not? And how much do we need to expand?
We need to expand enough to get that crossbite past the bottom
Okay.
so she can continue growing.
So we got to get the problems corrected. Yes, but if we're shooting for ideal, what would be the ideal amount of expansion at this age if you were trying to correct this discrepancy completely? We know that eventually it's got to be 10 millimeters wider than it is now. But how much of that should you expand right now to get if you wanted to get to ideal? 6 to 8. One of those numbers is right. The first one's right. Okay, so 6 millimeters. But why? Where does that other 4 millimeters come from?
Just natural growth.
Growth, right? So upper jaw is going to grow about 4 millimeters from the time of 7 years old to 26 years old. Again, she's about 7. So 4-ish. You know, she's almost 8. So maybe you got to take away a millimeter. 2 of those millimeters happen between about 7 and 9. Okay, go ahead.
How much do you think you would lose, though, or of that expansion would be dental, though, if you do 6?
That's a great question. So now we talk about so we've talked about wanting the upper jaw itself, the bones, to be 6 millimeters wider. So how much are we likely to need to expand in order to get 6 millimeters of skeletal expansion with the traditional type of expander? It depends on how it's designed, but you're usually going to get somewhere between, let's say, 55 and 75% of the expansion, average it out at about 60%, right? So if you're shooting for 6 millimeters of skeletal expansion with the traditional type expander, you're probably going to need to expand 10 millimeters in the mouth, which can sometimes be challenging because you're connected to the teeth. The expander itself is also tipping the teeth out. The lower teeth are tipped in. You typically have to do something to upright those teeth. The fact that she already has a crossbite on one side and the lower teeth are not as compensated as some can help us. But ideally, 10 millimeters at the screw, about 6 millimeters at the bone, and then growth takes us the rest of the way there, all right? Now, what about that's the transverse. What about the AP? What are you thinking we need to do with the upper lower jaws from an AP standpoint? We've already identified that the lower jaw, it has a prognathic tendency, right? So we're assuming that that's probably going to take care of itself and keep growing forward. And if that does keep growing forward, what needs to happen to the maxilla? It also needs to come forward. Now, has she demonstrated in her growth up to this point that this maxilla can keep pace with the mandible? No. And she's got, if anything, a longer and harder journey ahead, right? What's one of the questions you're definitely going to want to ask at this new patient exam to give you an idea of how big of a problem this may or may not be as she continues to grow? Family history, right? Did anybody in the family have jaw surgery? Did anybody have an underbite? All those types of things. But right now, we're kind of worried. Like lower jaw's growing very quickly, upper jaw's narrow and set back. Anything we can do to bring the upper jaw forward at this point is going to help us. So what might we consider in addition to an expander? A Lefort, yes, we'll take it to, no, I'm just kidding. Yeah, so we're gonna consider the non-surgical Lefort, or there you go, MSE and Facemask, protraction Facemask. Very good. Good job on remembering. So treatment recommendations. Now, we're in the primary dentition here, so we don't need skeletal anchorage necessarily in order to correct this jaw, or at least in order to get some changes to this jaw. Now, could you do an MSE on a patient this age? Yes, you can. In fact, I recommended one, well, almost this week I recommended an MSE in a 9-year-old, which again, I normally don't do. But they had loss of the dentition, they had early loss of the primary teeth, they had a huge class 3 discrepancy, and there was nothing to grab onto. So the 6-year molars were impacted underneath the E's, so we literally had no anchorage. So, I mean, could I do a normal expander? Yeah, I could do a normal expander, but then I'm just going to be pushing the teeth out. Like, I'm not going to be able to get good skeletal change. So my recommendation was, well, you can extract some teeth, baby teeth, and let these come in and get good anchorage and try to do it traditionally, or we can do a skeletal expander and move the bones the way that they need to. And that's up to you, right? But in this case, we have good anchorage. We have all of the primary teeth. She's young enough. So we've got great anchorage. So we don't need an MSE per se. So we ended up doing, and I know I've spent more time on that than we need to because the rest of the stuff is actually the coolest part, but we'll go through it quickly. We do an expander. Now, and this is not obviously the exact expander we did. You can see this was designed for a patient who they were trying to hold back molars here, and it also had the face mask hooks. Now, this case, we did not do a face mask on. And in hindsight, I definitely would have done a face mask on this patient in phase 1. Honestly, I'm not entirely sure why we didn't, but we didn't. We did an expander, so we corrected the transverse. Maybe there was a bigger slide, and we were thinking, okay, well, maybe the transverse is fine. Maybe there was no family history. There could have been multiple things that went into that decision. But in hindsight, and you'll soon see, I wish we would have done a face mask on this patient as well, along with the expander. All right? So here we are 1 year later. So, roughly 6 or 7, 8 months after the expander was done, because we did traditional expander, we expanded. We also only expanded about 7 millimeters at the screw, and in hindsight, would have done a little bit more as well. We do have more room. You can see the teeth are coming in. A year later, those lower Ds that we were worried about being ankylosed don't seem to be a big problem. You can see the left side did kind of follow suit. You can see the E's are actually starting to follow suit a little bit, which, may or may not cause a problem. So it seems to be something going on with those E's, and we're starting to see the development of the third molars, but no real major problems here. So now I want to show you, so here's the airway. So this head position is a little bit better than the first, still tilted back to some degree, but technically that's normal, 80 for an 8-year-old. So no huge concerns there. Patient isn't reporting any airway concerns. We still have an edge-to-edge tendency in the front, still have a good nasolabial angle, none of that's changed. Still pretty high angle here with the lower jaw continuing to grow forward, so none of that's changed. All right, but we look at the upper jaw width, and we went from 39 to, let's say, 40, almost 45. All right, so we got almost 4.5 millimeters or so, almost 5 millimeters of skeletal expansion. All right, which is good. We're going to get, at this point, she's maybe closer to 8 or 9, you get at least 2 millimeters more that she'll get on her own, maybe 2.5. So that would put us at 46, 47, getting really close there. Lower jaw, you can see, is about the same as it was. We still have some compensation of the teeth. You can see the lower teeth tilted inward. You can see the upper teeth still slightly tilted outward. So did we get as much expansion as would be ideal? Not yet. But we got some good changes, all right? We got some changes of the bones. Now, here's where we started. Here's where we are 1 year later. Now, obviously, I can't take credit for all of the transverse because she has had a year of growth. But since we understand growth, we know that at most, you would get about 1 millimeter of that through growth. So maybe we got, 3.5 to 4 of it with the expander, which would make sense if we turned at 7 millimeters, and maybe she got 1 millimeter in growth during that time. You can also see the changes in the nasal passageways as those have lengthened as she's continued to grow vertically and expanded as the expansion was done. So this is what that looks like on a 3D superimposition. So here is the growth of the upper jaw along with the changes that we saw with the maxilla. Again, with the expansion. So this happened over a 1 year time period, okay? Now, what drives me nuts is when patients are they are actually never like this, but other doctors, they'll look at things like this and they'll be like, oh, and they just don't understand or don't know or have never studied growth. They're like, oh, this is, the patient grew. I mean, you show me images a year apart. Well, yes, they are a year apart, but I'm next going to show you images 4 years apart. And you'll get to see, what happens with normal growth versus what happens when you do what we do, growth modification, right? So you can see the changes that have happened here within a year. And all the things that we would expect to happen have happened. The bones of the maxilla have moved outward. You can see at this point the teeth have probably started to decompensate to some extent. You can see the molar occlusion is pretty decent. And why is the lower jaw looking wider? What's happening? Why is that wider primarily? Because, that looks like way more than 1 millimeter. So why is that looking wider here a year later? Is this another golden ticket answer? All right. Why is the mandible looking wider? We know that it's only going to grow 1 millimeter, right, from about 7 to 26. So why is it looking wider? I think, well, you signed it first. You signed it. You said the lower jaw. Yeah, the lower jaw is growing forward, right? So we talked about that, the acceleration of the growth of the lower jaw. It's coming forward. As it comes forward, a wider portion of the mandible is coming forward with it. So the more that mandible grows, the larger our jaw size discrepancy is becoming. All right? We didn't calculate that into our equation, but when, if the lower jaw continues to grow forward, now you're shooting at a bigger target, right? You have to make, either have to bring the upper jaw forward more to keep it matching, or you have to widen it more to keep up with the transverse that's happening as the lower jaw comes forward. All right, so this is a view of the growth from the AP standpoint. Now look at this. Upper jaw is not keeping pace with the lower jaw. Look how far forward that chin is coming versus how far forward the upper jaw has come over that year. So despite our best efforts, I mean, obviously with expansion, you typically get some forward movement of the upper jaw. We're not really seeing a ton of forward movement of the upper jaw here. Primarily, this has resulted in transverse correction, right? We still are having this AP problem. The lower teeth are starting to retrocline to some degree, and we're seeing that vertical growth continue, right? This case is becoming more challenging and more challenging as we go along. All right, here's the view of the upper jaw here. Again, 1 year apart. You can see primarily the changes in the width. Look at the changes in the width of the upper jaw compared to the changes in the anterior position. The width is much more than the anterior position is. You can also see the ramus of the mandible there. So that lower jaw, well, actually, I don't have another golden ticket. I'm out of them. But why is there such a big change on the left side of the, do you see that? Do you see the ramus here? Why is there such a big change? Why is that side moving so much and the other side not so much? Between those two time points, a year apart.
It's not locked anymore.
She's not shifting. Yeah. So before we mentioned she was shifting. So again, you can see the significance of that shift here. All right. So now we're at 11 years. We're going to fast forward a few years. All right. So now we've had some growth. We've been observing things. Now, did our lower ankylosed teeth cause us problems? Maybe. It looks like we were both wrong about the open bite. She doesn't have a posterior or an anterior. She has a mid-arch open bite here. But can you imagine if you just put braces on this patient, that lower arch is going to level and you're going to have what kind of a bite? An anterior open bite or a posterior open bite? If that lower arch levels out. Lower arch levels, I know we don't talk a lot about comprehensive ortho. Lower arch levels, lower teeth are going to come down. You're going to have a raging anterior open bite, right? It probably didn't help us that those lower teeth were ankylosed. Maybe we should have gotten those extracted earlier. Maybe it would have helped level that out a little bit more. But now, again, we're not going to spend a ton of time here because we got to get to the other part of the treatment, and we're running out of time. I always spend too much time on the initial stuff. 8:18. Okay, so 11 years old here. Look at the smile width in general. Look at we have almost a bilateral posterior crossbite tendency here, especially at the premolars. All right. We still have a transverse discrepancy, which is getting larger because the lower jaw continues to come forward, and the case is getting more difficult to treat. Now, we're actually starting to see, because that lower jaw is growing, look at the profile. Our profile is suffering because the lower jaw is growing so far forward. That chin, the chin-throat neck length is increasing. Lower jaw is growing down and forward. Upper jaw is not keeping pace. And so we're seeing that nasolabial angle kind of increase a little bit here. And then when we look at the smile itself, we're not feeling that soft tissue smile because the upper jaw is still more narrow and more set back compared to the lower jaw. All right, so this is 4 years later. Again, the teeth came in. All right, she's got those wisdom teeth forming now. I mean, this is a forward head posture, right? I mean, look how far the airway, the airway looks amazing now. I mean, I'd love to take credit for it, but again, this is mostly head posture. I mean, to some extent, the expansion certainly helped. Look at the vertical nature of this case. I mean, look how dolichocephalic. This is not an easy case to treat. All right, so here is our dimensions 4 years later, or 3.5, whatever it is. Okay, that's normal growth. All right, maybe a half a millimeter, something like that. I mean, this is normal growth. So this is not growth modification. You can see the lower jaw. Why is it getting wider? Because it continues to come forward. The more it comes forward, now we're shooting at 46 millimeters at where the first molars are. The upper jaw has grown, half a millimeter or so. You can see at this point, maybe she was just sick, or maybe, she's having difficulty breathing. Maybe she's a mouth breather. We see those premolars tilting inward. That arch seems to continue to collapse, probably indicating mouth breathing. Probably should have recommended, if we didn't, lip taping or something else, maybe myofunctional therapy to help her support the dentition and maybe help prevent some of those teeth from coming in. but this is the superimposition over those 3 years. Now you'll see the change in the vertical growth, right? You'll see the change in the cheekbones. Like the face is developing, but it's developing downward, and we're seeing very limited transverse change, all right? So again, this is the superimposition for those 3 years of growth where we were just monitoring. Look at the forward movement. Look at how far the upper jaw has grown versus how far the lower jaw has grown. I mean, you look at that lower jaw, I mean, it's like a centimeter. I mean, that thing is flying forward, and the upper jaw is maybe like a half of a centimeter, like maybe half as fast. And the upper teeth are continuing to procline as this growth is happening. So, you know, back in the day, this is like, oh shoot, you know, you're probably going to need surgery, so do you want to do anything now or not? You know, because like we could do something and you make your teeth look better, but you're probably going to need surgery, all right? This is how we used to have to manage these cases because there's like no way to keep up with this, right? Or at least there didn't used to be. So getting back to the title of this case, MSE plus face mask, that's going to be our treatment recommendation, all right? So this is what that looks like. All right, now you can see here that the screws have actually not been placed yet. The reason I have this image is because after the MSE is placed, we will take a cone beam to measure the lengths of the screws so that we can ensure we get bicortical engagement and that we're not sticking it into the septum, or not this, well, either the septum, but that should be planned out in advance, or what more likely the inferior turbinates, right? You don't want to have them so long that they're in the inferior turbinates or that they are not bicortical. You need bicortical to get good anchorage. And again, you don't want them in the inferior turbinates because it doesn't feel good, can cause complications, nosebleeds, and so you want to avoid that, and it's painful. So this is the placement of the MSE before the screws went in. So we went ahead and placed the screws at this point. You can see that the appliance itself has propped her open a little bit. You can see the open bite there. That's going to get worse as you imagine as this levels out. This is going to be something that we're going to have to manage with the skeletal anchorage we have by intruding all of those posterior teeth and getting them out of the way, allowing the lower jaw, unfortunately, to rotate forward more. So we are basically chasing this lower jaw. We need to do everything we can at this point to get the upper jaw forward. Now, if you looked at these photos, how far in treatment do you think we are at this point, if you had to guess? Seeing the changes from where we started. A year and a half? What'd you say? Almost done? All right, what'd you say?
I was agreeing with Mike, 2 years ahead maybe.
Okay, all right. So this is the power of skeletal changes, all right? This was 8 months, okay? So we have skeletal anchorage. That appliance is attached to the jaw. Now what we've done, you can see there's these big spaces here between the molars and the premolars. So we're getting expansion, but then we're using our anchorage to push everything forward. The last thing we want to do is expand and protract and then just pull all the teeth back when we're done, right? We want everything to go forward. So while we have the anchorage to the teeth, we're pushing everything forward and consolidating our space here so that when this appliance comes off, we can drag those molars forward, effectively moving the upper teeth forward within the jaw so that we're not retracting the teeth and we have the most overjet possible within the jaw without angulation of the teeth problems or as minimal compensations as possible. So we're 8 months in here. Now, I would love to say like we finished in like 12 or 13 months. Like looking at this, I'm like, oh, that's super simple. But again, we are fighting the puberty growth spurt right now, right? So we are continuing, that lower jaw is continuing to come forward. So this is where we finished, all right? And it was 22 months, all right? So we had a long battle. Now you can see the posterior occlusion. It's not, you know, the game is not over yet, right? I mean, she's you know, done most of her growth, but there still could be latent growth. But look at the changes in the profile, look at the changes in the face, look at the changes in the smile. So that is growth modification that never used to be possible. We never used to be able to move the jaws to that extent. So you saw what moving the jaws looked like with the expander. You saw what moving the jaws looked like with normal growth over those 3 years. Now I'm going to show you what growth modification looks like with the skeletal expander. This is our pano. Of course, we got all the teeth in. We'll use some aligners to settle the bite. You can see here that our nasolabial angle has improved again from where it was. Still a discrepancy between the upper and lower jaws. We've leveled the occlusal plane pretty well. Obviously, we didn't have a huge effect on the mandibular plane, but you know, in order to correct the bite, we had to level the occlusal plane to some extent, which you can see here. Again, the airway measuring smaller on this one. Head position is a big part of it. You can see the superior airway, huge changes there, which is going to happen as you expand. You can see the condyles here are seated, so we're not, you know, posturing anymore. We are where we are. And here's our upper jaw width, right? So we are now at 50 millimeters, which we said originally was our goal. You can see that the lower is still at 46. So we were able to manage the teeth. We were able to distalize some of the teeth on the lower. And again, push the upper ones forward as the jaw came forward to help us be able to match the upper jaw and the lower jaw in an easier place to do so. Here was where we started before. So again, we have about 5 millimeters of skeletal change at this point. And this is what that looks like on the 3D superimposition. So this is those 22 months from the beginning of treatment to the end of treatment. And again, look at the lower jaw widen. That lower jaw is continuing to come forward as that expansion is taking place. But you can see the changes not only to the upper jaw itself, but also look at the nasal passageways, look at the sinuses. Now, I mean, I don't want to take credit for clearing up the sinuses, but the better you nasal breathe, the less likely you are to have these problems recurrent. I mean, it could have just been she was sick on one day and not the other. But again, think about that. That's the nose's job, is to clear things up like that. So it needs to be functioning properly to do that. Here's the look at the upper jaw itself. So you can see the forward and transverse movement. Even still, more transverse movement than forward movement. What we're going to do is we're going to scroll through these images and look up at the sinuses now. Now we're at the nasal passageways. Look at the nasal passageways open as the midface expands. Look at the room that you have within the nasal passageways as that whole midface is expanding. Look at when we start to get into the cheekbones there. And you can go all the way up. Look at the condyles, all right? So this is going to show us what happened to the condyles. Again, these are relatively stable from the beginning to the end. We're not seeing a shift one way or the other. That tells us that what we got is truly what we got. And then lastly, look here at the AP. Again, look how much mandibular growth over that period. And I wish we could have gotten even more maxillary protraction than we did, right? That's going to depend on how well they wear the face mask and also related to how you do the turns and how much you expand. So a lot of our AP correction you can see was with the teeth, but we did have some forward movement of the upper jaw as well. And the last image we have here is the volumetric image, which again kind of shows in 3 dimensions the changes that have happened. But look at the development of the mid-face. This is something that not even jaw surgery can do, unless you do a Lefort 2, which nobody does because it's risky and it, you know, there's complications. And but this is essentially, you know, this is essentially like a Lefort 3 improvement, if that makes sense, right? You're affecting change all the way up to the level of the orbits as you expand skeletally. And again, this is something that they would otherwise not be able to have happen. So we watch her transformation from where she started to phase 2, to when we get things going with the expansion, to when we get things off. And, you know, is it a perfect result? I've never seen a perfect result. But, you know, for a patient that 10 or 15 years ago almost surely would have needed jaw surgery, you know, I'll take it. I'll take what I can get. And will she get jaw surgery? I don't know, right? It's still possible. But even if she did have to get jaw surgery later, all of those other changes that you've seen are not going away. Those are there to stay, and she will end up with a better long-term result than she otherwise would have.